Hi, my name is Emily Wang, and I'm an associate professor and founding director of the SAGE Center at the Yale School of Medicine. The center is a unique collaboration between the School of Medicine and the law school that will work to stimulate community transformation by identifying the legal, policy, and practice levers that can improve the health of individuals and communities impacted by mass incarceration. At the core of our center are individuals that have been directly impacted by mass incarceration, faculty, staff, and students. COVID-19 has unmasked, yet again, long-standing health disparities fueled by our nation's correctional systems. And the recent deaths of Breonna Taylor and George Floyd and others have highlighted persistent societal racism and especially anti-Blackness. According to the Bureau of Justice statistics, over 6 million Americans, mostly the poor and people of color, are currently under some form of correctional control, and tens of millions are formally incarcerated. This center will address the deep-rooted racism in our country. It opens in a time when health systems must not only acknowledge their role in perpetuating the status quo of racism, but also exert our collective power in dismantling it. The establishment of the SAGE Center builds on our team's clinical experience, focusing on the health impacts of incarceration. In 2006, I co-founded the Transitions Clinic program in the Bayview's Hunters Point in San Francisco to create a health home within an existing community health center to address the adverse health effects I saw in patients returning home from incarceration. In the past decade, we've expanded to a network of programs, the Transitions Clinic Network, with over 40 clinics in 14 states and Puerto Rico, led by Dr. Shir Shavit at the University of California, San Francisco. Interdisciplinary teams are the crux of our model, where community health workers with histories of incarceration are embedded within primary care teams. Each week in clinic, I see the many different ways that our criminal justice system and our healthcare system create additional harms for people who've returned home from prison. People released from correctional systems have outside risks of death from overdose, cardiovascular disease, cancer, gun violence, and now correctional systems are epicenters of the COVID-19 pandemic. 39 of the 50 largest cluster outbreaks have occurred in correctional settings in rural and urban communities. Most of the thousands of jails and prisons across the country are in full lockdown with no visitation or programming. Many are depending on solitary confinement units and restricting movement among people who are incarcerated. Still, though, a majority of facilities have very limited testing, even as cases grow exponentially. Public health systems just don't incorporate correctional health into their mission, and because of this, partnerships between jails and prisons and our community systems of care are virtually non-existent. And you can see the repercussions of this now all over the news. Right now in San Quentin prison, outside of San Francisco, there are more than 1,600 individuals infected, those who are incarcerated as well as staff. This story is playing out all over jails and prisons in our country and doesn't just affect those that live and work in correctional systems, but also communities that, in which jails and prisons sit. Governor Newsom of California has ordered the release of 8,000 individuals to stem the outbreak. Decarcerating our nation's prisons and jails is a critical prevention and mitigation effort for COVID-19. However, the release of these individuals needs to be bolstered by many more community agencies and health systems stepping up to the plate. Prior to COVID-19, the return home from correctional facilities was difficult for our patients. There are significant barriers to getting health insurance, medications refilled, finding a primary care provider or an addiction medicine provider. There are legal barriers to getting jobs, food stamps, and housing. But in a pandemic, this is even worse. Patients don't have phones for telemedicine. Getting a primary care doctor is virtually impossible. Patients are also more likely to live in densely populated neighborhoods, homes, or congregate settings. They can't work from home, don't have the cash to pay for private transportation, and many distrust messaging coming from the public health officials and health systems. So throughout our network of programs, we're trying to address these barriers. In Connecticut, California, and North Carolina, we've started a statewide COVID-19 hotline so that correctional facility leaders have a single number to call to arrange medical discharge plans. This includes medications, medical records, and the appropriate referrals. But while we work on the individual level, our center is also really focused on identifying what solutions can address the structural barriers that lead to worse health outcomes, especially within our health systems. And it's this question I'm hoping our group will entertain. If we as healthcare leaders, providers, systems are committed to health equity, to tackling disparities, then I want to ask, what do our health systems do to actually invite, engage, and support people coming home from correctional facilities into our systems? How can we create communities between our health systems and correctional systems which are durable, meaningful, so that transitions home from correctional systems back into the community are safer, especially during COVID-19? Why does Medicaid coverage discontinue or lapse when people are incarcerated? COVID-19 presents the opportunity to rethink how we've structured our health systems to intentionally create barriers for communities that have been disproportionately impacted by mass incarceration. I look forward to brainstorming and discussing solutions with you all in the next few weeks.